Next speaker is our Professor Vincent Robert. She is the head of the Department of Pancreatology and Digestive Oncology in Beaujon Hospital, Paris Cité University. Her lecture title is How to Manage Investigations After a First Pancreatitis. Okay.
Thank you very much for this very nice invitation. I'm very honored and glad to be with you today. And I have a special thanks for Professor Ahmed Erhai for this organization and for this invitation. So let's talk to acute pancreatitis, and especially the causes and how to manage all the investigation we have to do to find the cause. So just to introduce my talk, just a few epidemiological data just to say that the incidence rate of acute pancreatitis really and significantly increased during the last decades, and it's similar for men and women. It increased in every part of the world, and excuse me, every part of the world, and you can observe that this increase was the same for biliary pancreatitis or alcoholic pancreatitis. So when we're talking about the causes, just we have to know that all the causes I will try to expose to you are balanced, influenced by genetics of background of individuals, and probably by microbiota. And it's completely different for each individual because it's really influenced and balanced by these two topics. So the first cause you know very well, of course, is biliary disease. The second one, alcoholic consumption, chronic alcohol consumption, and usually associated with tobacco and cannabis use sometimes. The third one, very important, it's all tumor, which can be benign or malign, cystic or tumoral tissue, malignant tumors. And we can also find specific genetic alteration specific for pancreatic disorders, of course. Probably an influence of metabolic syndrome, especially for tumors or for biliary disease. And maybe the role in a crosstalk between environment and immune modification, especially for autoimmune pancreatitis. So, of course, the first thing we have to do is to rule out biliary pancreatitis, which is very normally simple, with two key procedures, biological analysis and gallbladder ultrasound. And with a specific transaminase profile, which is the best biochemical marker when it is performed very early with a dosage less within the 2 first days, with a very high positive predictive value and negative predictive value, especially when transaminase are up to 3 times the upper normal limit. When it is associated with gallbladder ultrasound and that performed at admission to limit the risk of sludge, of course, due to fasting, we can find a very high sensitivity and specificity to find some stone into gallbladder. So the problem is if these two keys are not helpful and we have a doubt, so can we be helped by MRI? MRI is can be very useful, but sometimes not to detect very little microlithiasis, less than 6 millimeters in the main pancreatic duct, for example, with a very low sensitivity, and microlithiasis less than 3 millimeters into the gallbladder. So in that case, of course, we have to perform EOS if we have any doubt regarding the diagnosis after US, CT, and MRI. And let me remember the results of the APEC-2 trial for patients with biliary pancreatitis who had EOS at admission. Authors find very frequently bile duct stone or sludge in the main pancreatic biliary duct with EOS. So at the end, if we have any doubt, we have to perform EOS for a patient to confirm the diagnosis. So, of course, after we have to rule out chronic alcohol consumption, which can be very easy, of course, by interview of the patient, but there is some issues and concern I want to highlight, is that at the end, only 3 or 5% of chronic alcoholics will develop pancreatic disorders. And we know that frequently tobacco is associated with chronic alcohol abuse, and it highlight the fact that usually there is also associated risk factors as genetic variant, for example, or the role of microbiota, which explain that only a few people with alcohol abuse will develop acute pancreatitis. So it means that we have to be very careful regarding some atypical situations where alcohol cause can be debated. And 2 examples. The first one is acute pancreatitis. After a very long period of alcohol consumption, we have to search for another cause, and specifically for tumor. The second situation is acute pancreatitis. After a very short period of alcohol consumption, we have to search for other risk factors associated as genetic alteration, for example, for young people, or for tumor for a patient older, for example. So after that, of course, the main concern will be pancreatic tumor, and specifically adenocarcinoma. So let me remember you these 2 studies. The first one, they just looked to patients with pancreatic cancer, and we can observe that in 10% of this population who had pancreatitis within 2 years before the cancer diagnosis. So that's a very important point. And the second study is that if in a population of patients with acute pancreatitis, at the end, the over risk of pancreatic cancer in this population at 5 years will be around 2. So it means that we have to be very careful. Acute pancreatitis could be the first step of pancreatic tumors development. So to be very exhaustive, we have to propose very important and precise morphological workup, associated CT and MRI, both exam. And there is, of course, an interest for EUS for all these kind of patients to confirm biliary pancreatitis if needed, to rule out a tumor, to characterize some pancreatic lesion as for autoimmune pancreatitis, and to perform biopsies if you have any doubt regarding tumors. So, at the end, if the pancreatitis is not due to biliary disease or chronic alcoholic consumption, let me propose you some, to summarize all the causes we can find. So I propose you a threshold, 35 years, 40 years. It's not a strict threshold, it can be 42, for example. So for patients more than 35, 40 years old, the main cause can be obstructive pancreatitis due to tumors, of course, autoimmune pancreatitis, metabolic causes as hypercalcemia or hypertriglyceridemia, and we have to perform CT, MRI, MRI-CP, and EUS for this patient. For the biological analysis, you have to propose IgG for dosage only if you suspected autoimmune pancreatitis, calcemia, and triglyceridemia dosage. For younger people, for younger patients, the main cause we have to propose is genetic variants, anatomical abnormalities as pancreas divisum, for example, autoimmune pancreatitis type 1, type 2, metabolic causes. The imaging workup is exactly the same. I mean, the three exams, CT, MRI with MRI, CP, and EUS. And then for biological analysis, IgG4 dosage if you suspect autoimmune pancreatitis only, genetic panel testing, and calcemia and triglyceridemia dosage. So let me describe more the different cause, and especially obstructive pancreatitis could be due to a lot of different kind of lesions, which can be malignant as adenocarcinoma, of course, or neuroendocrine tumors, as we can see maybe in the second picture, of course, with an obstruction in the ampulla and a long enlargement of the main pancreatic ducts. It can be benign with IPMN, branch duct IPMN, first photo, or a mixed type IPMN, of course. And we can find also a lot of duct abnormalities due to sequelae after severe pancreatitis or pancreas divisum or malformation. So let's talk about hypertriglyceridemia-related acute pancreatitis, which can be severe hypertriglyceridemia when it is up to 10 grams per liter, which means that there is a presence of chylomicron, and we clearly know that there is increase of the risk of pancreatitis, which is correlated to the level of triglyceridemia, and the higher the level of triglyceridemia is, the highest the risk of pancreatitis is too. So in that case, of course, what is the cause of hypertriglyceridemia? There is different categories. The first, more frequent, is the polygenic form, which is leading by chronic alcoholism, but also diabetes, type 1 and 2, pregnancy, of course, and hypothyroidism. The other categories I primarily form are very, very rare. It's due to genetic variation of with a deficient on lipoprotein lipase, which is very, very rare, one individual for 1 million inhabitants. And the secondary form, it's autoimmune disease. It's also very, very rare. So now let's move to genetics and genetic testing for patients. Two situations in clinical practice. You have risk to find some genetic defect. For young patient with recurrent pancreatitis without any explanation after a very exhaustive workup, or for all patients, whatever the age, with acute pancreatitis and familial history of pancreatitis. You can see in this study that in that case, you have a very high risk to find some genetic variants. So the indication of genetic testing at the end, for patients for who you did not find any explanation to the pancreatitis, young patient, or for every patient with pancreatitis and a family history of pancreatitis. But also, as I explained you previously, for patients with risk factor found, but with atypical presentation. For example, patient with a severe but recent alcohol consumption, you have maybe to perform genetic testing because this patient had probably some genetic susceptibility to alcohol. Exactly the same for cause you find, which could explain pancreatitis, but the attributability alone of this risk factor can be debated. For example, moderate tobacco consumption. Or another example, it's anatomical variation as pancreas divisum, and we know that usually we can find some CFTR variant associated in the half of the patient with pancreas divisum and acute pancreatitis. So in that case, the panel we propose in 2024 is right now we test 10 genes in clinical practice So PRC1 gene, the most well-known gene, which is an autosomal dominant inheritance, which leads to hereditary pancreatitis. And the other gene is PINK1, CFTR, CTRC, the calcium sensing receptor, TRPV6, CPA1, CL hybrids, which are autosomal recessive inheritance. We can find some heterozygote variants, and usually patients have this kind of mutation and have all the risk factors associated, as malformation, for example. And the two new genes we analyze since January in France, it's PNL and CL3B. So for all these patients, we have very, very heterogeneous clinical and morphological presentation. So let's move to autoimmune pancreatitis. You know that we have two kinds of pancreatitis, type 1, type 2. Type 1, which is a part of a systemic disease, IgG4 disease, and it is specific with the lymphocyte and plasmocyte infiltration into the pancreas. It's usually men, more than 50 years old, which can present a pseudotumoral presentation, and there is usually involvement of other organs. The type 2 is usually granulocyte epithelial lesion we can find in the epithelium of the duct with a duct destruction. There's no, the sex ratio is 1, and it can be usually associated with IBD in a third of the patient. So two completely different autoimmune pancreatitis, probably two completely different diseases with two completely different physiopathology mechanisms. So let me show you some pictures. You will see some involvement of the entire gland, and with a pseudo rim, you can see just around the pancreas with diffusion signal highly for the entire gland. We, of course, can see some disruption of the main pancreatic duct with no enlargement, upstream enlargement of the pancreatic duct. And you can see also some associated organ involvement in case of IgG4 disease with a large cholangitis, for example, or for retroperitoneal fibrosis, or for kidney involvement. So when you suspect autoimmune pancreatitis, it's mainly regarding imaging features. When you have some argument criteria, then you can, regarding also the clinical presentation, of course, but it is by both presentation. So, and to conclude, when you have some multiple acute pancreatitis after cholecystectomy and with transient elevated liver enzymes as transaminase, you have to evoke two different diagnoses, LPAC syndrome and sphincter of Oddi dysfunction. The first one, the LPAC syndrome, is due with a genetic disease due to mutation leading to abnormalities of the MDR3 protein. And to make the diagnosis is at least the presence two criteria on the list. I mean, onset of biliary symptoms before 40 years of age, recurrence of biliary symptoms after cholecystectomy, and radiological criteria has spots, comet tails, or intrahepatic lithiasis on imaging. So to make the diagnosis is quite easy. I mean, there is acute pancreatitis with transient transaminase elevation, and then you have to ask the radiologist for a specific ultrasound of the liver and to search for very, very little spot into the biliary tree. So, and the second disease you have to propose is dysfunction of the sphincter of Oddi, which is of kind dyskinesia related to functional disturbance in muscular tone control. The I should say the physiopathology is quite complex, not really well known, and a lot of literature was proposed with not elucidated solutions. So maybe it can be intermittent biliary obstruction, some kind of fibrosis of the sphincter, and the presence of microlithosis. So in clinical practice, can be sometimes difficult to make the diagnosis. It included clinical and biological criteria, of course, with relapse of acute pancreatitis with elevated transaminase rate. You can be helped by biliary scintigraphy, which is not 100% positive. And of course, with biliary MRI and MRCP, you have to rule out LPAC syndrome before to conclude to this kind of diagnosis. Well, so my take-home message is that when we had a patient with acute pancreatitis, could be maybe simple, but not so simple at the end, because all the causes are really balanced, as I said, by the genetic background and microbiota background of the patients. And of course, we could have biliary disease, but can be associated maybe with some kind of alcohol, but maybe with metabolic syndrome and hypertriglyceridemia, for instance, or also immune disorder, which will lead to biliary disease. Exactly the same for tumor. Tumor, we know that metabolic syndrome, obesity, overweight, diabetes are main risk factor for pancreatic tumor. Alcohol, for example, is associated in quite 100% with tobacco use. And specific genetic alterations are very frequent in a population of alcoholics who develop pancreatic disorders. So at the end, I think that we are aware to search for different components to complete and find the real cause of acute pancreatitis. So thank you.